Ladies and gentlemen, welcome to another episode of the Global Health Impact Network podcast. I'm your host, Martyn Eeles. Today's guest, we have Arian Nachat, founder of Pallity. It's a pleasure to have you here.
Thanks so much for having me, Martyn. I'm really excited.
So before we kick off today, why don't you just give a quick introduction of who you are so the listeners get to know a little bit about you?
Sure. So my name is Arian Nachat. I've been a physician for about 20 years now. I started out with my boards in emergency medicine. I then did a master's in traditional Chinese medicine and then boarded in hospice and palliative medicine and became pain trained as well. I founded Kaiser Permanente's first inpatient integrative symptoms management service. And during the course of the pandemic, I became fairly distraught by the lack of resources available to patients and families and, frankly, hospital systems when it came to issues related to palliative care and end-of-life care. And so I founded Pallity.
So let's talk about what the current problem is and, how does your company solve this problem?
Sure. So I'm sure everyone witnessed over the course of this pandemic, this horrific state of affairs where people had not planned to get super sick. People who were previously healthy, people who were vibrant and had no prior medical issues were suddenly getting extremely ill with COVID and finding themselves in a situation they never even contemplated, having to think about their own mortality, thinking about what kind of invasive procedures they would or wouldn't want to have done, and finding themselves unexpectedly on a ventilator. Not to mention the families who, because of COVID, couldn't come into the hospital, couldn't actually interact with their family members. And we were witnessing these heartbreaking episodes of patients dying on iPads and saying goodbye to family members through technology. And I think what that did is it really opened up the Pandora's box, which we culturally in this country have struggled with for many years, is how do we talk about this final journey that we're all going to go on? We all get a one-way ticket here. We're all going to ultimately one day die, but we don't really want to talk about it. And so what the pandemic did, and what I feel really sort of triggered the shining of a very large light on a very big problem, is that here's this journey we're all going to go on, one that is super important, and how we do it is something we have more say in than most patients and families realize. We had an opportunity to change that narrative and to change that dialogue so that patients and families really are in control of what that experience is like and can plan for it accordingly. And in an ideal world, really make plans that then can be executed by their healthcare teams that are consistent with their values and who they are and what they want on their last few months, days, years here on Earth with us.
Okay, so I was going to ask, why is this important? But I think you've just kind of answered that question.
But I can talk about why it's needed now.
Sure.
So, when you look at the demographic in the United States, I don't think anyone in healthcare really doesn't know or realize the enormity of the change in demographics to an older patient population. And the fact is that palliative medicine, which is a specialty that deals with patients who have what's known as a life-limiting diagnosis, are patients who potentially, given that we have all these technological advances in medicine, can now live sometimes for decades. And so we now have this very large swath of patients who are coming into a state of chronicity of their illness. And so we have about 63 patients that are projected to need palliative care services by the year 2035. Currently, it's at 14 million. And there are only 7,600 palliative care physicians who are trained in the United States to perform those specialty level conversations and care. And so there's a huge gap happening between what is currently available as a resource, and then also how do we get that resource to the patients and the families and the healthcare systems. If you take a look at the data of what's out there currently, about only 17% of hospitals in rural America have palliative care services of any kind. And that's an enormous gap. So if you're lucky and you happen to live in, San Francisco, Chicago, New York, Miami, large major metropolitan areas of the country where there are training programs, you will have access to palliative care more so than somewhere else. But if you're in rural Iowa, or in a part of the country that does not have a training program, only 17% of those hospitals even have access to palliative care resources.
Okay, so who can benefit from this?
Sure. So to be honest, I think we are at a point where everyone could benefit from this, right? So hospital systems know that this is a resource that they don't have much access to. We're only making 500 new palliative care fellows a year on average. And that doesn't take into account the attrition of the physicians in the field, correct? So if you take that into account, hospital systems benefit from this because if they don't have the ability to put a palliative care team together and have that resource available to them, this is an option for them. For healthcare systems, in terms of payors, their entire financial model is based on the fact that they want to deliver care early that is preventative, that is streamlined with the patient's best interests, and ideally is a lower cost resource. So a patient who does not want to be on a ventilator, who winds up on a ventilator, is something that is distressing for everybody, right? It's distressing for the family. It's distressing for the patient, obviously, although hopefully they're unconscious and unaware of what's going on. But it's a very distressing time. And so if they have the ability to advocate for themselves in advance and can make what their desires and needs are known, then it takes the burden off of their loved ones who, I have to tell you, my worst day at work is when I'm sitting in an ICU and I have 10 family members sitting around an ICU conference room table, and they're all saying to me, wow, we don't know what this individual wanted. We are heartbroken and we don't want to make the decision. That's an enormous burden to put on a family. And so this really is a gift that patients can give their family members by commemorating in writing and having those conversations facilitated by an expert who knows how to have those conversations and really talk about what are the risks, benefits, and alternatives of treatment options that are being proposed to you. And are they consistent with what you want for yourself? Does doing that next line of chemotherapy actually buy you much time, or does it give you more symptoms that you have to manage? Is that what you want to do with whatever time you have? So it really is a system and a platform that is intended to service every single member who touches the healthcare system in their critical illness state of being.
Okay, so where can people access it?
That's a great question. So the Pallity Platform is intended to be accessible from anywhere by anyone. So patients can access it, in the palm of their hands in the form of an app on their phone or an iPad or a desktop. For clinicians, similarly, they can access the clinician side of the portal to get resources in education and CME and better understanding, and can collaborate with the actual palliative care teams that are on the Pallity Platform so that they can provide guidance to the clinician if the clinician wants to conduct the conversation themselves, or if they want to hand that off to us to manage for them. Similarly, healthcare plans, payors, industry can partner with us. The intention for Pallity is to really make it accessible for everyone everywhere. And so depending on where you are in your journey, it may be your physician's office that contracts with Pallity, and we wind up providing the services for you. Or it may be you as a patient have found us and are interested in contracting with a palliative care clinician to provide services.
So why now?
Why now? So why now? Because finally we are having conversations that are honest and direct about the fact that we are mortal. COVID has ripped off that Band-Aid. It has essentially exposed the gaps in our healthcare system in a way that, while those of us in healthcare may have seen them previously, I think it's shown a huge, big, enormous flashlight on where all the challenges are for patients, for their families, for the clinicians, the amount of distress people are in talking about this in terms of making decisions for themselves or their loved ones. now is the time to change. Now is the time to say, wow, we do recognize that we can do this better. We don't want to say goodbye over an iPad. We don't want to leave it to our children to have to decide what to do if we are not able to speak for ourselves.
So why will it get worse?
Well, I think our patient population is just aging, right? The number of seniors, the boomers, so to speak, that number is in the millions, and it's increasing at a rate that, we've been talking about this for at least a decade or two in healthcare, how this is coming, and it's not coming anymore. It's here. So we have an aging population. We've made amazing advances in medicine and in healthcare, where we now are able to keep people alive with an illness that several decades ago, probably they wouldn't have survived. And now we have the technology at our disposal to help people stay alive for longer. But everyone's personal definition of what being alive means, what means quality of life to them, is very different. And so, one of the joys of my job is that not any conversation I have is ever the same as another conversation I have. Every family is different. Every human being who is going through a life-limiting illness experiences it differently in the context of their own life and their own social system and their own belief system. And those patients want to have agency. They want to have a say in how they do this. And so at Pallity, our goal is really to give patients and their families and their caregivers the agency to inform their healthcare teams what is an acceptable quality of life to them, what they're willing to put their bodies through, that they fully understand what their choices are, and then put it in a condensed format that is legal, that is traceable no matter where you are. So that way the healthcare teams are delivering care where you're at.
Okay, so I'd like to talk a little bit about Pallity. Where are we at the minute with the platform?
Sure. So we're in the process right now of developing the MVP. We are in negotiations with several different companies who are interested in beta testing for us, where they have the patients available to us, and we have obviously the clinicians and the expertise. And we want to start putting these patients on our platform and start really beta testing to see, is what we think those patients and those families and clinicians want really what they want, or are there things that we need to modify or adjust for? And then over time, the intent is for us to have a very robust platform where, if you imagine it as the spoke of a wheel, we are the spoke, and coming off of that spoke are going to be access points for all of the services that a patient would need. When I talk to patients and families, they're so super distressed. They don't know what they need. They don't know where to access or find what they need. So the analogy I like to use, for lack of a better analogy, is if you imagine an old VHS tape, which is now dating me. But if you pull out an old VHS tape and you take all that ribbon out and you put it on the table, the consumer experience of this, and frankly, I think it's also a clinician experience of this, is they have this huge jumbled mess of a VHS tape in front of them, and they get told, hi, I know you're really sick and there are these resources available to you, but here's this jumbled up mess. Go figure out how to get what you need. And we really want to take that away. And so what we hope to do in developing the platform over time is to make sure that all of their needs that they could possibly have, whether it be skilled services, PT, OT, speech therapy, nursing care in the home, caregivers in the home, long-term care facilities, services like infusion services that come into the home, their pharmaceuticals, the psychosocial support networks that they need in terms of mental health support, whether it's social workers or psychologists, or in the extreme cases, psychiatrists that they need to talk to because they're so distressed by their illness. We want to curate essentially the full package for them in the same location, so that as they're going through their journey, everything they could potentially need is accessible to them. And then over time, because of our experience and our expertise, we are hoping with advanced patient monitoring and AI to really be able to identify the patients who are in distress before they get to the point of being in extremis, and take those patients and kind of pull them back off of the ledge and help them get the support that they need before they're so distraught that they wind up in the emergency department, they wind up in the ICU, they wind up having things done, interventions done that they didn't necessarily want, and really help them stay ahead of the curve. Because what we are experts at is anticipatory guidance. Another analogy I like to use with our patients and families is I'm your Sherpa, okay? Having a critical illness is like climbing Mount Everest. I can help you up the mountain. I can also help you down the mountain, but I know where the crevasses are. I know where you're going to get into trouble. I know where the pitfalls are. And I have the resources, the education, and the expertise to help you whichever direction you want to go in.
Wow. So let's talk a little bit about the goals for like where do you see yourself like in the short, medium term, and then obviously the long term?
Sure. So in the short term, we want to get this MVP up and running. We want to partner with our collaborators and do the beta testing, get as much information from that. You know, the healthcare industry is a very complicated beast. I've been in healthcare long enough to be able to really speak to various aspects of it. I joke around about the fact that I have that 30,000 bird's eye view. You know, I'm an emergentologist, so I do acute life-saving things, but I'm also a palliative and hospice specialist. So I also do chronic illness and life-ending, end-of-life experience care. I've done inpatient, I've done outpatient, I've done Eastern, I've done Western. I literally have seen the healthcare chessboard from every possible vantage point. I've also been a patient, and I've been through the side of what it's like to not have control and to feel that fear and anxiety associated with being a patient and what's going to happen next. So in the short term, our goal is to really identify whether our ethos, our belief of what patients and clinicians and systems need is correct. We'll beta test it, we'll get feedback, we'll iterate on it. You know, healthcare is a living, breathing creature. And while I think I have a great concept and a great sense of what patients and clinicians and systems want and need, I want to prove that. I'm a scientist. I'm a researcher. I have a great hypothesis. I want to prove that hypothesis. So in the short term, that is the immediate goal, is to build the base platform, get some folks on there, test it, see how we're doing, get the feedback. In phase 2, the goal will be to expand those partnerships and collaborations to bring in the various industries that we talked about earlier in the podcast in terms of, you know, skilled services, pharmaceuticals, biopharma, equipment, other offshoots of clinicians who might need specialty interventions, whether it be an interventional anesthesiology group, if it winds up being a hospice agency. We'll start bringing in all of those partnerships. And as we've proven that the model is working and we've gotten that data, have the AI algorithms start to kick in and have the AI data start to inform us on how to really provide improved value-based care for the insurers, for the payors, and be able to give real-time feedback as to what's working and what's not, what's helping patients accomplish their goals and have the quality of life that's meaningful to them.
So let me ask you this: if any of the listeners want to like help test the beta, how can they do that?
So once we have the beta platform up and running, they would contact Pallity. They would tell us how they would like to partner with us. We would identify how we would do patient information sharing in terms of the electronic medical record. Our AI platform is going to be agnostic in terms of we are not going to have PHI that we will retain, but the AI algorithm will obviously curate that information and give us feedback on how things are going. And so we would partner with them individually, whether it's a large, you know, oncology group, neurology group, nephrology group, cardiology group, anyone who has a patient who has a life-limiting diagnosis. And we would have them enroll onto the Pallity platform, whether it's the clinicians or the patients, and we would partner with them to start doing the palliative care service delivery.
Well, that's awesome. Is there anything else you'd like to discuss? Because I've got no other questions for you.
I think it's just really important for people to recognize that the narrative around palliative medicine and end-of-life care in this country has really been a Pandora's box, sort of a taboo. No one really wants to open it. And I think that if anyone were to talk to anyone in their family, invariably they'll find that really the biggest anxiety that families have and patients have is the unknown, right? We don't really know what happens when you die. We don't really know what it is that we're going towards. And I really think that there's no one I've spoken to, certainly over the last year since Pallity started, who doesn't have a story that they themselves experienced with themselves, with their family members, where they go, God, I so could have used that. I wish I knew I could do XYZ. I wish I knew who to call. God, I wish that you were available to take care of my family member when we were going through this. And so while it's a difficult conversation, I think it's one that at the end of the day, when people really have a quiet moment and they're thinking to themselves, what is something I can do that would give me peace of mind? I think everyone could agree that knowing what you want and what your loved ones want and having the ability to access that is the biggest gift of all.
I absolutely agree. Well, listen, it's been an absolute pleasure having you on. Thank you so much. It's been great to learn more about you and Pallity, and we look forward to seeing you on the journey.
Thank you so much, Martyn. I really appreciate the time and everyone's energy and excitement around what Pallity is working on, embarking on doing.
Perfect. And again, thank you for all the listeners who listen to this, and we'll see you on the next episode. Bye-bye.